Hello friends, this is Professor Dr. Sameen Afzal Junejo from Hyderabad in Pakistan. I operated a case of a rocky hot cataract grade 4 with a brown nucleus. And as a routine part of my surgical steps, needle cystotome was used for capsular access. In this case, can opening technique was applied to perform a round capsular access. As the nucleus was extremely hard and I am not interested using the dye to color anterior capsule in order to avoid many complications, hazards of using the dye. The dye is the trypon blue, which sometimes stains the corneal endothelium and can give rise to intraocular inflammations and sometimes extremely severe postoperative reactions. A diamond keratome 2.78 millimeters was used through surgical limbus to create a full thickness through and through corneal incision, and the approach was surgical limbus, which is approximately 2 millimeters away from the anatomical limbus. Viscoelastic solution was injected into the anterior chamber and on the surface of the cornea to magnify the media and bring about a good clarity during surgical intervention. Side port was created at about 8 o'clock position with a straight diamond keratome. We will use the Phaco power of 75% in this case with 550 millimeters of mercury vacuum and 38 cc fluoride. Again, viscoelastic solution was injected into the anterior chamber in order to provide a better lubrication and coating of the corneal endothelium to avoid the corneal endothelial burn. Easy tip was used in my Cataract Easy Oakley machine from Switzerland. A central trench was created engaged into the nucleus, pulled and divided the nucleus into two halves through equator. Equatorial approach is the best approach to divide the hard nucleus without any trouble or without any extra effort. This is again the equatorial approach. The nucleus was divided into fragments with the help of a cutting ball chopper. Again the equator was engaged at the tip of the phaco, and the fragments was taken up one by one, keeping the bevel at the lateral side rather than the vertical side to avoid corneal endothelial burn. The nucleus was further divided into fragments and taken up one by one through the phaco tip, keeping the bevel at the lateral side in order to avoid direct burn to the corneal endothelium. This is how the extremely hard nucleus was removed by the technique of stop and chop. OVD dispersive was injected before going for the irrigation and aspiration of cortical matter with the help of a two-way Simcoe irrigation and aspiration cannula. This is my ideal instrument to perform irrigation and aspiration of the cortical matter and the tiny portions of the epinucleus. Viscoelastic solution used at this step is most essential in order to avoid the posterior capsular rent. Here we use the Simcoe cannula, and you can see that the cortical matter is being aspirated at 360 degrees. Whenever we perform a phaco on a hard cataract, we should always try to keep the phaco tip exactly in the middle of the pupil at the interpupillary area, not beyond that. It should be quite away from the corneal endothelium, and the bevel direction should always be on the lateral side, either medially or laterally. It should not face up or down. In both the conditions, if the bevel side is facing up, there are chances for the endothelium of the corneal burn, and if it is down, then there can be a capsular rent. A one-piece IQ foldable intraocular lens was injected exactly into the bag. This intraocular lens is very easily self-fixed into the bag because this IOL has got a very good haptic memory. After implanting the IOL into the bag, we will try to irrigate and aspirate the retained viscoelastic solution in the anterior chamber and also behind the nucleus of intraocular lens to prevent postoperative transient rise of intraocular pressure and postoperative cellular reaction. The viscoelastic solution has been removed as much as possible. Intracameral cocktail injection with the help of a cannula is injected into the anterior chamber and behind the iris. This cocktail injection contains 2 drops of pilocarpine, injection dexamethasone and moxifloxacin antibiotic. This is, on the contrary, the best preparation to form the anterior chamber and avoid the postoperative inflammation, chances of any inflammation. Pupil is immediately constructed and provides very good support to the implanted intraocular lens and deepens the anterior chamber. So the pupil is getting smaller and smaller, and that is a very good sign to keep the IOL exactly in the bag in the central position. My dear friends, there is no any evidence of red eye, chewing of the conjunctiva or tear anywhere in the conjunctiva, because the incision which was made was at the surgical limbus, which is about 2 millimeters away from the anatomical limbus. Thank you very much, my dear colleagues. If you like this video, please subscribe my channel and also push the like button and bell icon so that you can receive and enjoy my future videos. Thank you very much again.